On behalf of the Center for Occupational Environmental Health, I would like to welcome you to our webinar presented by Dr. Robert Harrison and Yassine Khan of LOHP SASH program. A few housekeeping items first. You'll be muted during this presentation. If you would like to ask a question, please enter it into the online Q&A box. We will save time at the end of the webinar when Yassine will be asking Dr. Harrison questions that you guys have posed. All participants who have logged in today with their registration email will receive an email tomorrow with a recording to the full live presentation and an evaluation form that will qualify participants for a certificate of completion with 1 continuing education contact hour. Once the evaluation is completed, you will be able to access and print or save your certificate. At this time, I would like to present Yassine to everyone, and she will start telling you a little bit more about the SASH program.
Thanks, Jessica. Good afternoon, everyone. My name is Yassine Khan, and I work with the Labor Occupational Health Program. And we host a program called SASH, which stands for the School Action for Safety and Health Program, which is a statewide initiative that helps school districts reduce injury and illnesses among school employees. So we are really excited today to have Dr. Bob Harrison with us here. And Dr. Harrison has been with the California Department of Public Health and on faculty at the University of California, San Francisco in the Division of Occupational and Environmental Medicine since 1984. So thank you so much, Dr. Harrison, for being here with us, and I will turn it over to you. Oh, you're muted.
Okay, got it. Thanks, Yassine. Jessica, I'm really glad to be here. I'm going to do a screen share. I'm going to focus today on school worker health and safety and COVID-19 vaccination in particular. I'm mostly going to talk and show a bunch of pictures. I'm going to have a few little pointy head slides that's going to make you look at some figures and some graphs, but not very many. And I only have like one really sort of medical type slide to show you about how the vaccine works. I am a faculty member at UC San Francisco, work for the state health department. And since March of 2020, since the beginning of the pandemic, have been doing a lot of consulting and advising and research, and now actually seeing patients in my practice at UC San Francisco, long haulers, which we could talk for a full hour about just what I'm seeing and what we are learning about long COVID or long haulers. So as I'm going along, and I'll have about a half hour, just jot down your questions, then put them in the chat, and hopefully we'll have plenty of time. So as of yesterday, you might have all read that Governor Newsom announced that beginning April 15th, we're going to be opening up vaccination to every Californian 16 years or older. And you can see that at the bottom of the slide here. And then there's in little print, it says vaccination of people younger than 16 is going to start as soon as the COVID-19 vaccines are approved. That's because the vaccine studies were done on between 30 and 40,000 people, but they were done in adults. The Pfizer vaccine is now being tested in teenagers and children of puberty age with some early promising results, but those are not yet in, and those are going to have to be submitted to the FDA. So it's probably several more months or perhaps even to the end of the year before we have a vaccine approved for COVID-19. So 16 years is the cutoff. That begins April 15th. You can see every other category is now vaccinating. So it's not in green, it's a blue light here, which includes healthcare workers, which were in our first phase. So our frontline healthcare workers, workers in nursing facilities, residents in nursing facilities. That was followed by 65 years of older in phase 1B, which included agricultural and food workers. And then you can see our audience here, education and childcare. That rolled out over the last month. So although they were in group 1B in January and February, because of the vaccine shortage, only those 65 and older were generally able to sign up and get vaccinated. And then about a month ago, we opened it up to age 16 or older with medical conditions, disabilities, illnesses, living in homeless shelters and the like, and certain other congregate, we call them, work environments. And then 50 years, which is now open. And just in about a week, it's going to be vaccines for everybody. Let me just emphasize that while we're vaccinating, employers must keep work safe. In California, in the middle of December, our Occupational Safety and Health Administration, or Cal-OSHA, passed an emergency temporary standard for COVID-19 in the workplace other than hospitals and clinics and other healthcare facilities. We had a standard for COVID-19 in healthcare that we had passed several years ago. That's called the Aerosol Transmissible Disease Standard, but we didn't have one for the non-healthcare workplaces. So this includes schools, prisons, jails, food and agricultural workplaces, grocery stores, manufacturing facilities. So we now have that as of mid-December, and that requires that employers provide many prevention, or we call them mitigation strategies, which include distancing, that's at least 6 feet, unless the employer can show that they are not able to do that, adequate ventilation, face coverings or masks, surface cleaning and disinfection, and testing. So there's pretty comprehensive requirements under that Cal-OSHA standard that apply to schools as workplaces, and those all remain in place even as we're vaccinating. The Cal-OSHA standard was based on the best science and research that have been done since March when the pandemic started. And again, all that remains in place. So as I'm talking about vaccination, I like to say sort of hold that thought, right? Try to keep two things in mind at the same time, that as we're vaccinating and seeing great effect, as I'll show you in a minute from the vaccine, we also have to remain vigilant to keep all of this in place until we can see the true light at the end of the tunnel. As of yesterday, and you can go online and see this in the New York Times on their website, a very nice figure. So here's one of the figures I promised you that you'd have to walk through with me. So this says, at the current pace of vaccination, everyone could get a shot this year. And in fact, it's looking like even before the end of the year, and well before the end of the year, there should be vaccine available for anyone who wants one. Over the weekend, we reached, I think it was for the first time, 4 million shots that were administered. California has administered over 20 million injections. Governor Newsom quoted yesterday that if California were like a country, we would have administered the 5th greatest number of vaccines worldwide. We've administered over 120 million throughout the country. And if we look at that pace of vaccination, so this is the current pace, this is where we would be if everybody got at least one shot. You can see April 4th, we were at 32%. By June 14th, we'd be at 70%. On June 29th, we'd be close to 80%. And by July 21st, we'd be at 90%. If we were on our current pace by the end of June, 80% would be all adults 18 years of older in the United States. So that's actually important to keep in mind, because we have something what's called herd immunity, which is generally considered to be about 70 to 80% of the population. So if we subtract the children, either 18 or 16 years and younger, which are not yet eligible, there's not a vaccine for them, to get to 70 to 80%, almost all adults in the United States would need to receive the vaccine to get to that herd immunity figure. So that's why I'm talking to you today, to hopefully answer questions or um, concerns that you might have. Many people in the United States have waited. There's a lot of questions about taking the vaccine, and I want to be sure that we have enough time for me to answer those, for you to continue thinking about it if you haven't made your mind up. So here's the figure. I just wanted to show you that over 100 million have been vaccinated very safely. And I think this is really an important aspect to keep in mind. When the studies were done, they were done in really light speed compared to the research that's generally done when vaccines are tested and rolled out. So the research involved about 30 to 40,000 in the three manufacturers that we have, Pfizer, Moderna, and Johnson & Johnson. A lot of people, we needed a lot of people to be able to run these statistics and see a difference. And in those vaccine studies, the side effects were also pretty minimal. There were a few people that had severe allergic reactions. In the first 100 million doses that were given, we've seen very, very minimal severe allergic reactions, very much like the research studies that were done. And we're also seeing that the effectiveness in the real world is mirroring the research that was done in the vaccine trials. You can see that almost 70 or over 75% of the population greater than the age of 65 has received at least one shot. If you look overall in the United States, we're at about 42% over the age of 18, comprising a total of 32% of the population. Governor Newsom announced yesterday that most pandemic restrictions are going to be lifted to reopen the economy by June 15th, if we're on pace to vaccinate, and we don't have another surge. Well, I'll talk about that in a minute. And I call this the fastest way to achieve some normal life in the United States, which is what really everybody has been looking forward to. There are a couple of caveats to lifting these restrictions. One is that face coverings will continue to be required. So those masks, I don't think we should be expecting to drop the mask requirement anytime soon. We still may be having some more rigorous testing and monitoring of our populations, particularly certain workplaces, and that will probably or should include teachers in certain locations, even after we vaccinate and reopen the economy. The governor and our public health officials are talking about eliminating those color tiers, which some of you may be familiar with. We have purple, red, orange, and then yellow, and those correspond to rates of COVID infection in the community. And if we still see our rates dropping, then all counties would be in the lowest or yellow tier, and some may even be lower than the yellow tier, which is what we call a green tier, except the green tier really corresponds to, you know, the reopening in most situations. California now has the lowest case rate in the country, and here's a map that shows you the states that have, and I think it's important probably to look at the states that have the highest rates on the one hand, and then the lowest rates. So you can see in the West Coast, it's in this kind of a green, this, I don't know what you'd call that green color. This is the lightest green, the lowest rate. But California is also extremely low. Look at these northeastern states and Michigan, highest rates, and that's where we're seeing concern about the variants. I'll talk about that also. If California stays at the lowest or at among the lowest rate in the country, this gives us the pathway to reopening, which is what the governor announced yesterday. So keep an eye on this. The Pew Research Center had a poll of Americans. So this is all United States adults, a large poll that was done about a month ago. And this has changed a little bit, but not too significantly. So take a look here first at this figure on the left. So in dark blue are the people who said they would get a vaccine. And then in this green color are folks that said they would not get a vaccine. So look at the green bar below here that would not get a vaccine. In September and then November, we reached a high. We actually had about half of Americans said in September they would not get a vaccine. As the vaccine rolled out after we passed the election in November, and as the vaccine rolled out, you can see that about 30% here in early February said they were either definitely not or probably not get the vaccine. This is dropping. Some California data that I've seen has this now about 20 to 25%, about a quarter of adults. So as I showed you the figure to reach herd immunity, the concerns or questions that this group of Americans have is really important, because in order to get to that light at the end of the tunnel to reopening, it's really important that as many Americans as possible are vaccinated. When you look here on the right, the major reasons why folks are concerned about getting the vaccine: side effects, the rapid development and testing too quickly, how well they're working, mistakes from the medical system, don't think I need it, I'm not in an area or feel like I'm at risk, and I generally don't get vaccines when they come out. So those are the leading reasons, and those are really stayed about the same over time. There isn't much data that I've seen until yesterday, actually, and I'll mention this because I didn't have time to put it on a slide. This is data from frontline healthcare workers. These are folks like myself and my colleagues and coworkers and our staff at UC Medical Center. We started vaccinating in late December. We have about 75 to 80% vaccinated. But when you look across the board about the vaccine acceptance among healthcare workers, you can see that it's about 70 to 80%. The green here have not yet decided and don't plan to get vaccinated. I'm particularly worried about the nursing homes and assisted care facilities. And you can see that there's about a quarter who said at the beginning of March that they don't plan to get vaccinated. This is among staff. I want nursing homes and assisted care facilities to reopen. And they are starting to reopen to visitors and family members, because our families and our elderly in these facilities have been shut in for over a year. And that really has major consequences for their mental and physical health. And about a third to a quarter of all deaths in America from COVID-19 have occurred in these facilities. So they're really critical. And that's why we began vaccinating these folks first at the end of December. I think of the vaccine as the best way to protect myself and my family and keep me safe at work. I work in an outpatient clinic. I see work-related injuries and diseases in the clinic at UC Medical Center. So I have patients coming in to my office. My office is not set up for big spaces, great ventilation. There are a lot of staff working in a pretty small clinic area. My exam room is probably 6 feet by 8 feet, and I'm probably being pretty generous. And there could be, a patient and a couple of family members, and then I might have a student on a normal day. So we're all crammed into this little room, and I know the ventilation could be beefed up. It wasn't set up to flush out that air. I was wearing an N95. For those of you who see me, you can see I have a beard. It's not perfectly fit. It's better on my face than a surgical mask. And then I would wear another I would wear a face shield on top of that. But honestly, I would go to work and I'd come home at the end of the day and I would feel anxious and worried. I wanted to see folks. I don't want to just do telehealth and telephone and video visits. When I got the vaccine in January, I came to work and one of my staff said, "Dr. Bob, it looks like you've lost 10 pounds. And I said, you know, I think I lost 10 pounds of anxiety. I was just so much more relaxed. And that's been the experience of a lot of friends and family and colleagues after they've received the vaccine. It also has given me a window that I can visit my daughter. You can see Emily there, and my grandson Jasper, who is obviously, I think he's the cutest two-year-old on the planet. And I Zoom him, but I can now, if I'd like, go and visit him. My daughter is a pediatrician, and she was vaccinated. Jasper has not been vaccinated. Obviously, he's 2, but unfortunately, my whole family, my daughter, her husband, and little Jasper, they all had COVID in November. I didn't know whether my daughter brought it home from the hospital. You know, she was wearing her N95, she was taking care, or whether Jasper brought it from his daycare center. They had to pull him from daycare. They had to close that daycare center down for 10 days while all the other kids went home in his pod to quarantine. Fortunately, everybody was fine. This is to say that I know that Jasper has immunity, at least for a good 6 months from November when he had his COVID. So to me, this is one of the great benefits of, on a personal level, of being vaccinated. Now, the vaccine is safe and effective, and I talked about that earlier. I want to add, and I have this in red, that as of about a week ago, there was an important study that was published by the Centers for Disease Control, the CDC. That was in 5 areas of the country, and it focused on healthcare workers, and it tested their infection after they were vaccinated. The trials of the vaccine, these 30 to 40,000 that were studied by the 3 vaccine manufacturers, measured as their endpoint infection with symptoms. COVID-19, when it causes infection, only results in symptoms about half the time. The symptoms of runny nose, cough, loss of sense of smell, gastrointestinal symptoms, and so on, and fever. So that only occurs in about half the people. And so in those studies that were done, the researchers were not able to answer the question, did the vaccine prevent people from getting infection when they didn't know it, or asymptomatic infection? Did the vaccine prevent infection and they didn't know it? And that was really important because we want to know, does the vaccine prevent me from getting infected and then transmitting it to someone else and not knowing that that happened? And the study that came out last week in the real world of healthcare workers who were vaccinated, they had a COVID test that they did on themselves once a week, whether or not they had symptoms. And they found that among the group that was vaccinated, that very few people were infected and didn't know it. And that was really good news because the vaccine is now shown to prevent infection. That means that I probably can't pass it on to someone else. So that leads us to what we're presently reading about some verification of vaccination, right? If airlines or cruise ships or concert halls or baseball parks might ask us to either attest or show some evidence that we have been vaccinated, because that would ensure that we could then be with other people in large crowds or larger crowds, and we're not going to be infected and not know it and pass it on to someone else. So how does the vaccine work? This is my only sort of very pointy-headed slide. There are two ways in which our vaccine works. The Pfizer and Moderna vaccine, those are messenger RNA vaccines. And then the J&J or the Johnson & Johnson, that works through an adenovirus. And in both cases, the vaccine takes fragments of genetic material that mirror or are like the coronavirus. And in the case of the Pfizer and Moderna vaccine, that little RNA, which is this red squiggle here, is coated in a little tiny fat bubble. I mean, it's like a super microscopic fat bubble. And that fat bubble is able to merge with the cell of your arm and release that little piece of genetic material that then tells our arm cell to produce proteins which migrate to the outside of the cell, and these are called the spike proteins. And those spike proteins are then telling our immune system that there's something that looks like the coronavirus spike protein, but is not. So it's a mimic, it's a mirror. And then it fortifies our immune system so that if we do get exposed to the real coronavirus, which is operating in the same way, producing the real spike proteins, our immune system is immediately revved and ready to go and prevent infection. The J&J vaccine gets that genetic material in through a dead or an inactivated adenovirus, which is a very common virus that causes many different kinds of infections in humans. And it gets this little genetic material into the cell through an adenovirus and produces the same kind of spike proteins. In both of these vaccines, the mRNA dissolves, so it's gone, and the adenovirus cannot replicate. So there's no chance that anyone could get infected based on the biology and the mechanism of these vaccines. This was the first healthcare worker vaccinated in New York City in December, Sandra Lindsay. She had some marvelous things to say after she got the vaccine. She's continuing to speak about her experience. The anaphylaxis, that's a severe allergy reaction, is 4.5 per million doses. So it's about what we'd expect in any vaccine that we have on the market, like the flu vaccine, the shingles vaccine, the measles, mumps, rubella. They all have about the same severe side effect risk, which is why when we get the vaccine, we sit and are observed in our car or in the conference room at a distance from somebody for 15 minutes, just to make sure that we don't have this immediate reaction. We started out by vaccinating the highest risk first, and I think this has turned out to be a really effective strategy. I talked about the nursing facilities, our frontline healthcare workers, and then the accessibility for teachers over the last, I think it's really been about 4 to 6 weeks now. Food and agricultural workers have been very hard hit as well. Meat packing and poultry plant workers, warehouse workers, food and restaurant workers, warehouse workers, grocery store workers. This is a picture of Mario and his 2 cooks in my favorite restaurant in San Francisco, where I've been eating brunch for years. This was early in the pandemic. And you can see that they're standing here in a crowded little kitchen. And they turned out unbelievably good food from a very small space. This was before face coverings. I remember taking this picture. I said, Mario, I want to see you in the kitchen. Mario's the owner. And I said, are you going to get face coverings? And he said, yeah, they're on their way. The next week I came back and everyone was in face coverings and they still wear them. Fortunately, this restaurant survived the pandemic, got a small business loan, and I stopped there on Sunday to try to get in at 9:30, and there were lines out the door. So I didn't eat there, but I was super happy to see that my favorite neighborhood restaurant was surviving and could still feed the neighborhood. So let me then talk finally about variants of concern. So you heard probably a lot about these variants. As the virus enters the cell, the real virus, not the vaccine, the real virus enters the cell, it makes copies of itself and replicates by the millions and then billions. And that's what causes in some of us, our immune systems to be overwhelmed, for us to put out these proteins that cause a lot of inflammation and lead to our most vulnerable being hospitalized or dying. And as the virus replicates, it's given the opportunity to mutate, and that's normal. That's what happens. And that's how viruses evolve and have remained on Earth for millions of years. They're really smart. And the predictions were a year ago with the coronavirus that there would be a mutation about every 30 to 40 days and that we would pick up new genetic sequences of this virus. And it's turned out to be almost exactly on target. In countries that have been very hard hit with COVID, where a lot of people have become infected, there have been mutations in this virus, and those are called the variants. And the variants are of concern for two reasons. One is the vaccine that we developed and were tested were to the original coronavirus strain. The concern is whether the vaccine will be effective against these variant strains from the United Kingdom, South Africa, Brazil, or California. So far, it looks like they're largely effective against the variant strains. But these variant strains look like they also may be more highly transmissible. And here's the B117 variant, that's the UK variant, which is probably in part responsible for the surge that we're seeing in Europe. Many of those European Union countries are in lockdown mode because of this B117 variant. It's widespread in the United States. And think back to that map I showed you with the dark states in the Northeast. Those look like they're reflecting the estimated share of cases from this UK variant. And here's one state, Michigan, which was in dark blue on that map. And you can see the percentage of cases that are isolated, where the virus is isolated from someone who's infected. And look at the rise here, up to about 70 to 75% of all COVID cases in Michigan are this variant. And then you can look at the curve of the all virus cases that have been detected in Michigan and the percentage of the UK variant, which is rising in exact parallel with all cases. So in California, we haven't seen the widespread B117 variant. So what we're trying to do, as is said very nicely by our public health officials, is we're really in a race against that variant. Vaccinate so that the virus can't mutate or become endemic or widespread, and increase the transmission and the numbers who are infected, hospitalized, and die. So I just want to end and just reemphasize that we're keeping most protections in place. I mentioned that even as we hopefully reopen in the middle of June, we're going to be not giving up our favorite face covering. By the way, all face coverings are not the same. We could talk or answer questions about the type of face coverings. There's very good guidelines from the Center for Disease Control on the better face coverings and how to wear them. And for me to get back to read my favorite book to my grandson, I'm vaccinated. I'm not wearing a face covering. He's had COVID, so this is okay, right? As of about 3 weeks ago, to be able to do this with our families. So with that, I will stop. And Yassine, you want to field some questions?
Absolutely. Thank you so much, Dr. Harrison, for that lecture. So the first kind of group of questions are about employer requirements and worker safety. So the first question is, in your opening slides, you mentioned that employers are required to provide testing along with requiring social distancing and masking. This is the first time I've heard of the testing requirement. Do state agencies have the same requirement?
Well, testing is recommended for nursing homes, for long-term care facilities. And they've been doing it for months now. Testing is recommended for school districts. There's excellent guidance from the California Department of Public Health. There's a Safe Schools Reopening website that has great materials for school districts to take advantage of rapid antigen tests. They're called the Binax test kits, which are, if they're done frequently, are pretty accurate for the diagnosis of COVID and screening asymptomatic infections that are transmissible. So the questioner is technically correct in that it's not an OSHA requirement for surveillance testing, as I call it, in schools. But I recommend it particularly in districts where there are high rates, either based on the county or the local community, of COVID infection. Now that may change. We have to keep an eye on that as our rates in the community go down and as more teachers and staff in schools are vaccinated.
Thank you. The next question is, if you or your staff have had COVID-19, what would you consider the grace period afterward where your risk of contracting or transmitting the virus is minimized? And as a follow-up, are there still benefits to being vaccinated if you have already had COVID-19?
Before I answer that question, a couple of our listeners chatted in the response, something I should have added. They're absolutely right, that employers must provide free testing to exposed workers if they are exposed at work. So I was answering the question about monitoring, but absolutely correct that if someone has had an exposure, that is required under the Cal OSHA standard to provide that free testing. So that has not changed even with vaccination. So that's important to point out. But stay tuned. As we learn more, Cal OSHA may eventually revise that requirement, but right now, if someone's exposed, even if they've been vaccinated, they should be offered a test. There's still a tiny chance that somebody could get infected. Okay, let me answer the question. And the question was, Yassine, about grace period. Mm-hmm. So 2 weeks after the last vaccine dose, I think that was the question. How long?
So the question was, if you have had COVID, how long are you safe kind of afterward? And should you still get vaccinated if you've already had COVID?
Oh yeah, so someone should still get vaccinated even if they've had COVID. The CDC guidelines are 90 days, and that's based on early research after infection where someone's immunity was measured, their antibodies, their protective kind of armor against infection. That's actually been measured out now to about 8 or 9 months. So it looks like after 8 or 9 months after infection, there's still antibodies. However, the antibody response to infection is lower than the antibody response to the vaccination. So vaccination is still recommended even if someone has had a COVID infection. There's no time period that I'm aware of. There's no sort of grace period. So if the vaccine is available to everyone or to you now or will be on April 15th, regardless if and when you were infected, then I recommend taking the vaccine.
Great, thank you. As sort of a follow-up to that, talking about worker testing requirements, someone said that they are requiring everyone to be tested at their work site, regardless of whether or not they've been vaccinated, but they've been getting a lot of pushback from folks that have already been vaccinated and don't want to have to continually be tested. So can you speak to that?
Yeah, great question. So that question is testing necessary in the vaccinated? Right? If someone's been vaccinated, and as we see more and more people vaccinated, I'm getting that question a lot. And so far, I'm recommending to test, to keep testing, even if you're vaccinated, even if I've said that that study that came out last week found very good protection against infection, it is still not perfect. And the guidance from the CDC and our California Department of Public Health have still not clarified or answered or made a clear recommendation on that question. I am looking at the research data now. I think that we may reach a point where we could make testing of the vaccinated optional and not absolutely necessary, because I'm starting to think from the research data that's coming in that the chances that somebody will become infected once they're vaccinated are very low. But I'm still keeping my, my microscope on that, because I still feel like we're still a little bit early to absolutely answer that question. We still have this issue of the variants and whether our vaccination is going to be outpacing the variants, and we're not going to have a fourth surge in the spring. And so we're just in the spring. My allergies are now just flaring up. So when my allergies calm down by, May or June, and we see that we have this under control, I would feel from a kind of a worker protection point of view better about relaxing the testing.
Great, thank you. So in schools, if one student or one teacher tests positive, should the whole class go on quarantine? And how would ventilation factor into that decision of whether or not the whole class should be quarantining?
Well, I think it totally depends if that whole class had exposure. So if there was close interaction, and close is, I'm still defining it as 6 feet, although I know that there's now this 3 feet versus the 6 feet issue. So when we say the whole class, if let's say, I don't know how many kids, let's say there were 20 kids and they were sharing a classroom space and one kid was positive. And let's say we didn't know much about the ventilation. Let's say there's a MERV 13 filter in the ventilation system. Let's just take some hypotheticals. And those kids were wearing face coverings, which is supposed to be. How good do we think those face coverings work? In the judgment of the investigative team who's tracing the context of that positive kid, do we think that those kids were distanced and were wearing face coverings, or did they have them down over their noses half the time? Because I know that life is not perfect. So if there's a potential for exposure, then those kids need to be quarantined. because they've not been vaccinated. We don't have a vaccine for those kids. And then we have to look at the contact outside of their classroom pod or their bubble, however we define that. The whole school may not need to be shut down, but and that's the idea of keeping kids in pods or bubbles so that we don't have to close the whole school. New York City is going through a lot of discussion and controversy because in New York City, if there are 2 cases that occur different in time and space, then the school closes according to New York State guidelines. New York City guidelines. So in New York City, if you had one kid in class 102 at one end of the school and another kid was on the second floor upstairs at the under end of the school and was positive, and they happened within 2 weeks of each other, according to New York City guidelines, that school closes.
Wow.
And that's kind of driving communities a little bit nutty about that. So I hope I answered the question. I think it depends on whether there's contact with the other kids in that classroom. Having observed personal protective equipment and face coverings in many different settings, I'm a little bit on the skeptical side that people wear it perfectly.
Sure. Makes sense. Okay, so the next question is, would pool testing be of use in school settings?
Yes. So pool testing is this idea that we can take
Oh, okay. I think you're frozen.
Thank you, everybody, for being patient. We'll just wait just a moment to get him back.
Oh, there we go.
There he is. Okay,
Great.
All right, sorry. I don't know whether it was my end. Oh, I think it was, there we go. Can you hear me now?
Yes.
Okay, sorry about that. So pool samples is this idea that we take a lot of swabs, a lot of samples, either 5 or 10, put them together, send them to the lab. And if the pool sample comes back negative, then we know that everyone in that pool was negative. If the pooled sample comes back positive, one of those 5 or one of those 10 people was positive. And so then we have to go and run the samples or retest every one of those people to find out who the positive was. When the positivity rates are really low, and that's generally less than 1%, then pooled sampling can work because it can be very efficient and really drive down the costs of doing the testing. The labs have to be set up and capable in their scientific analysis and their methods to do the pooled sampling. So it's not possible just to say, I'm going to change from individual samples to pooled samples without talking to the lab and making sure they're certified and capable of doing it.
Sure. Okay, great. Okay, so the next group of questions are about vaccine facts. So can you talk a little bit about what made it possible to develop this vaccine at such a fast speed in comparison to other vaccines?
Yeah, I forgot to mention that actually. The mRNA, the messenger RNA technology, was being researched for about a decade before the COVID-19 virus. So it was being used to research vaccines for other viral diseases. So this idea of taking a little snippet of this RNA and putting this tiny fat capsule and getting it into the cells was pretty far along. I see Tracy says it's also used in veterinary vaccines. That's great, Tracy. Thank you. So that technology was on the shelf in January of 2020 when coronavirus emerged from China. And so the challenge was then in ramping up the vaccine trial, not in understanding the messenger RNA technology. The same thing was true for the adenovirus, for the J&J vaccine. Adenoviruses, that same technology has been used many times.
Great, thank you. Next question is, how can it be called a vaccine if it does not prevent infection but only reduces symptoms? How can we say with certainty that the vaccine does not have any negative long-term effects if we don't have data to show that yet?
Great question. We can call it a vaccine under emergency use because the FDA can issue an emergency use vaccine based on the efficacy in these large scientific trials. Permanent approval for the vaccine is going to come after we see what's called the effectiveness in the real world populations. And there are several studies that have been published, and I'm sure more to come. The first study was actually from Israel. Israel has vaccinated about 60% of their population. The second question is about preventing disease symptoms versus preventing just infection. And because of the immense toll that COVID has taken in terms of hospitalization and death, it was important to get the emergency use vaccine out and show that it prevented hospitalization and death in these research studies. Although infection is certainly important and people can feel lousy, I mean, I'm not discounting, and we have a whole research program now in the United States on long haulers, which includes people that have had COVID infection and never were in the hospital. So I'm not meaning to say that that's not important, but the emergency and the crisis really was the hospitalization and the deaths. And we were able to show that the vaccine prevented those. Personally, that's what probably dropped my 10 pounds of anxiety, because I could personally deal with getting infected and feeling lousy for a week. I wouldn't want to be a long hauler, right? That could happen. But when I thought about the consequence of being hospitalized and not having any visitors, or not, feeling better and then all of a sudden feeling bad and dying, that was a much more substantial issue for me.
Thank you. The next question is, when will we know how often and how many vaccine boosters we will need to maintain protection from additional strains?
What I've learned is that we're talking about the fall or the end of this year. So those studies are happening. Measurements of the antibody levels, the immunity levels after the vaccine that was given in December and January, those are happening prospectively. So we'll know if immunity drops. We'll also know whether the variants are more highly infectious and whether these vaccines are protecting against the variants. Because you're right, the Moderna and the Pfizer vaccine was studied before the variants. So this was kind of like the original strain, and we showed it was effective in that population. But those vaccines are now being used in other countries where we have a lot of these variants, and we'll know whether they're effective there. And then those companies are now also gearing up to change the messenger RNA and the adenovirus to instruct ourselves to make slightly different spike proteins that are going to mirror those variants. So I think we'll know by the end of the year whether or not we're all going to have to line up again and get a booster.
Great. If you are vaccinated, do you still need to quarantine if you've been exposed under the LOHP emergency temporary standard?
Not according to the Centers for Disease Control recommendation that came out a couple of weeks ago. For the general community, Quarantine is not needed if you've been vaccinated and have no symptoms. So if you feel well, you've been vaccinated, you're exposed to somebody, you don't need to quarantine. I don't know if Cal OSHA, oh, Laura.
Oh, Laura
Stock.
says,
Oh,
yeah.
perfect. Yes. So Laura knows the answer. You still need to do it under the emergency temporary standard. Okay. Public health says no to quarantine, but I guess the emergency standard still says yes to quarantine.
Thanks, Laura. Okay, so can you repeat the difference between the RNA importance of the Pfizer and Moderna and J&J vaccines?
So 2 shots, right, for J&J, sorry, 2 shots for Moderna and Pfizer, 1 shot for J&J. So 1 and done for the J&J. 2 shots, 3 or 4 weeks apart for Pfizer and Moderna. Wait for 2 weeks to get maximum response. The studies show that both are about the same in protecting against hospitalization and death, highly, highly effective for hospitalization and death, about the same. The J&J vaccine was slightly less effective against symptomatic infection. So it's about 95% versus 75%, the mRNA versus the J&J.
Okay, great. Have any comparison studies been done on the main 3 kinds of vaccines in terms of side effects based on the age, health, and conditions of the recipient?
So side effects in all the vaccine studies, greater in older and among women. And I don't think anybody's quite sure why that is, particularly the women over men question. I mean, I've seen some speculation, but I don't think anybody's sure why that is.
Okay, there's a specific question also about side effects. Someone said, I'm concerned for my 17-year-old who's almost 18 for him to get the vaccine. He has a history of anaphylaxis to more than 1 allergen or trigger, and he has asthma. He was not eligible for the Pfizer vaccine. They also say, my mom and dad's older sister got their first vaccine through Pfizer. My mom had a really bad headache and felt malaise. Now she's concerned about getting the 2nd dose because of worse side effects. What would you recommend in these 2 situations?
Great question. So in the first, the 17, almost 18-year-old, if he has a history of really severe anaphylaxis that you and your doctors think were probably connected to vaccination, then I would talk about it with your healthcare provider, but I would be hesitant for him. That would be one of the relative contraindications to getting a vaccine, is having had a previous really severe anaphylaxis. The second is, now I forgot. Yassine, what was the second question?
It was their mother had headache and side effects.
Right. Yeah, so it is true that in the vaccine studies that the 2nd dose side effects were a little bit worse than the 1st dose. That being said, it's very variable. My side effects from my 1st dose were worse than my 2nd dose.
Oh, interesting.
So go figure. In both cases, my 1st dose was really mild. You do need to really take the 2nd dose. The 1st dose gets you about 50, 60% immunity. The 2nd dose gets you to that 95. So it'd be really nice if your mom could go get the 2nd dose.
Oh, I think you're frozen again. Do you want to try turning off your camera? I think that worked last time. Thanks everyone for your patience. Hopefully Dr. Harrison will be back on with.
Looks like we just lost him for just a second, but I'm sure he'll hop right back on again if everybody just wants to give him just a moment. Technology has been so fun. I'll take this second to go ahead and remind everybody that tomorrow we will be sending out an email that's going to have the presentation recording, the evaluation, which will take you to your certificate of completion, and any resources that were mentioned today or that Dr. Harrison had on his slides will also be part of that email / the website. So feel free, again, if you need to finish watching it tomorrow or rewatch anything, it will be available. And it looks like Dr. Harrison is back. Let him get a second.
I'm so sorry about that.
That's okay. Welcome back.
Yeah, I'm back. Yeah, so I hope your mom is able to take the second vaccine. I think it's personally it's probably worth her risk. I think she could feel crummy for at most two or 3 days. That's what usually happens with the second dose.
Okay, so the next question is, can you speak to the large number of miscarriages and stillbirths that are being reported now that pregnant women are being vaccinated?
I have not seen that data. The CDC is still recommending that the benefits of vaccine outweigh the risks of vaccination in pregnant women. That was about 2 or 3 weeks ago. I haven't seen any other data. So the questioner, if they have information on the source of that, I'd love to see it. I don't know.
Thanks. So the next question is, I believe herd immunity assumes equal probability that any individual will encounter an affected person. I suspect that there are pockets of the country where a higher proportion of the population will choose not to be vaccinated, and thus herd immunity may never be reached in those areas. Do you think this will be of significant concern and may prolong the pandemic?
Yes, I think there's no question. I agree with your analysis that there are going to be areas that might be hotspots, that we're not going to see the entire country covered with sort of this blanket of herd immunity, that there are going to be areas with lower vaccination rates, where we're going to see the virus continue to have many outbreaks in populations. And so it's not going to end until it ends, and so we're going to have to keep an eye on those through next year. I absolutely think that after everyone has had the opportunity to be vaccinated, there are going to be varying levels of vaccination participation. It's going to be vary by country, by state, by community, county.
Okay, thanks. And a follow-up question to that is, if a large enough amount of people don't get vaccinated, should we expect to see more variants?
That's the issue. That's the vaccine versus the variant race. So it's possible. Yeah, it's absolutely possible that if there's pockets of transmission and high rates that emerge again, if we were to have, let's say, a fourth surge or another summer recurrence that occur in areas of the United States that have lower rates of vaccination, that affects all of us, because as our economy reopens and we're getting on airplanes again, great. I mean, I think it's wonderful that we're, going to be able to see the light at the end of a tunnel. We're going to be back into the same, reintroduction of possibly more transmissible variants into other parts of the country that either have not been vaccinated as much, or even areas that have been vaccinated if those variants are more transmissible. So, that's why it's absolutely, we're sort of all in this together. I mean, think of it internationally. The United States is far ahead of most of the world in having vaccines available. I feel incredibly fortunate to live in the United States, in California, where at least there's this choice that we're able to get it. Most other countries don't have that available to them. That means that if I'm thinking of traveling to Brazil, I'm not going to travel there until I see that the variants have not emerged, that my vaccine here is going to cover me if I go to Rio.
Right. Great. Thank you. The next question is, do face coverings, distancing, and airflow change recommendations? Oh, I'm sorry, airflow change recommendations change in any way if we know that we're dealing with a more infectious variant?
I think it makes it even more important. Yes. I don't think the recommendations change. I think the current recommendations stay in place, but I think as I saw these variants emerge, I felt that ventilation, all those layers of protection, all those mitigation strategies that I laid out at the beginning, those become even more important, including ventilation, I think becomes important. I mean, I don't think it changes. I don't think any of our recommendations change for how to implement good ventilation systems. It just means that they definitely need to be there until we see that we're out of the woods.
Mm-hmm. Thank you. The next question is kind of a follow-up, but what factors contributed to Michigan experiencing a surge because of variants, but California not experiencing a surge?
Yeah, I don't know the answer to that, actually. It's a really good question. We don't have the B117 nearly to the same extent as they do in Michigan. And the question is why? I mean, we have a California variant strain here, but it's not as highly transmissible. Good question. I don't know. Why are we seeing that map in the Northeast, including Michigan, where we're seeing those more highly transmissible strains? Does it have to do with population? I would imagine it must, I'm just guessing, has to do with introduction of those variant strains in those states, the way people have been moving.
Thank you.
I mean, did the New Yorkers go to Michigan and they're not coming
Yeah.
to California? Are people from Detroit not visiting LA? That's what I'm guessing.
Travel patterns, yeah. Okay, so the next question is, will we start seeing more RNA vaccines in the future for protections against other infectious diseases? Do COVID vaccinations pave the way for more RNA methods of immunization?
Yeah, I think so, but I'm not sure what is in the pipeline at those companies because RNA vaccines have been under research and development for a decade, as I mentioned. But I don't know the specifics of what the next, what's on the menu for Pfizer and their mRNA vaccine, or for Moderna. I did read, for what it's worth, the guy that was the genius behind, I think it was a genius behind the mRNA technology, has moved on, and he's now trying to find the holy grail for the influenza vaccine. Because right now we have to have an influenza vaccine every year because it changes, it mutates. He's trying to find sort of the holy grail that would give us one shot and protect against all strains. So he's definitely moved on. So at least I know he's thinking for the next pandemic.
Yeah. That's great. Okay, well, I think that is the end of our questions. So thank you so much, Dr. Harrison, for joining us and for answering all of these questions. We really appreciate your time.
Thanks, Yassine. And I'm sorry I got frozen a couple of times.
That's okay. It's bound to happen. Okay, so I'm going to turn it back over to Jessica now.
Again, thank you also. I just want to say thank you from COEH to both Yassine and Dr. Harrison. I want to thank all of the audience for your thoughtful questions and participation in today's webinar. You can join us May 12th for SASH's next webinar, Managing Stress and Building Resilience Among School Employees. And we really hope that you guys got as much out of this webinar as we We did. So if you have any other questions, feel free to email us at cohce@berkeley.edu. And remember to look out tomorrow for an email that will have your evaluation and your copy of the recording. All right. Thank you. Everybody have a great rest of your day.